So here we are at the AATS Mitral Conclave. It is day 2, and I'm thrilled to be joined by an esteemed colleague and a good friend, Dr. Irving Kron, who many of you know. Irv is chair of the Department of Surgery at UVA, and Irv, you've really been instrumental in really giving us some knowledge about ischemic MR. So hopefully giving us some knowledge. So I'm going to ask you a loaded question. Where do we stand with knowing what to do with severe ischemic MR and what have the trials taught us?
Well, I used to think that I understood ischemic MR, and where degenerative was the hard one. And now degenerative is really simple. There are 50 great ways to repair a valve, and they work. But ischemic MR, I have to say, my ideas have changed about it. So, and that's the point of trials. I would have guessed wrong on the trials that we're going to speak about, and the point is we just don't understand it very well. The key is the disease of the ventricle, not of the valve, and we got to understand that better.
But it is. But in the studies, and I know you've been intimately involved as both senior author and as lead author on these. I mean, it is the ventricle, but the ventricle can get bad, or the areas, and then the valve gets a little tethered and stretched. So tell me the first, I mean, the big trial that came out, the first one that caught a lot of notoriety. Mike Acker was the lead author. You were the senior author. What was the take on that?
Well, we designed the trial to answer sort of two questions. The question was, is the mortality higher for replacement, which I believe
I would have thought
absolutely.
so. Yeah.
And the second is, was the recurrence that much of an issue? And I would have said, if you do operations right, because we all know how to do them right, then it wouldn't recur. And it turns out that the answer is incorrect. It turns out that repair versus replacement, at least in the short term, at 1 year, has equivalent mortality rates. They're at least statistically equivalent mortality rates. But the recurrence is real. And so about a third at a year have moderate MR. Not many severe, and the moderate doesn't tend to increase, but they have moderate MR. Now they do as well, they feel okay, everything else is good, but they have moderate MR. And you have to understand, the trial was designed, you couldn't leave the operating room with any MR.
Okay.
So the point is that not a bunch of people failed in the operating room.
So, I mean, was there, I mean, it is counter. I mean, it's you would have said that repair was better, and were these patients selected? I mean, you all have done a lot of things with end-systolic volumes and end-diastolic volumes and all those things. In this study, were these patients selected? I mean, was there a selection bias in any way?
I don't believe so. I mean, basically, they were randomized without us knowing about it. You had to present with severe MR. The randomization occurred in the operating room. Okay. And people pretty much played by the rules.
So does that mean? I'm going to come to the other study. Does that mean right now, if you have severe MR, you're going to revascularize that patient? Should you replace the valve or try to repair the valve?
Sometimes.
Thank you, Senator.
Sometimes.
You do well in a federal hearing.
Yeah,
I like that.
I think so. I got this. I've learned the Virginia way, man. I got this down. Just a southern
surgeon shuffling along.
That's right. Anyway, the point of it is that I would have said it was illegal to replace a valve, and I think it's legal now. So what we decided to look at was, what about the patients? Could we predict recurrence? And it turns out that if you had a repair and you did not recur, you did better than other groups, both the other groups. Your ventricle got smaller, and it's statistically significant. So there's no doubt that if you have a successful repair, you're going to do better.
But does that have something to do with the ischemic burden of the ventricle? In other words, is there something else going on there?
I don't think so.
You don't think so? Okay.
I think we can predict, and so this is what we looked at. We looked at it was pretty straightforward. We looked at the patients who didn't recur and ones who did. Surgical study. And we have this way of predicting now who will do well. But the key item in this, if you have a basal aneurysm or akinesis, or what you see on echo, you see a kind of a bulge there. Right. The type of repair we do today is not going to prevent recurrence, the so-called reduction annuloplasty. And remember, we fix these valves in one plane. We need to learn to fix them in 2 planes, which you've been telling me for years.
So you're saying that if you have akinesis, dyskinesis of the basal inferior posterior wall, you need to fix that. You need to do something in addition to an angioplasty.
I think you need to do something different. You either replace the valve, or in some studious fashion, we got to learn some techniques to treat the subvalvular apparatus. Now, I've written a little bit about how you do it, 20 here and 20 there, but we really have to study it.
You do it inside the ventricle or outside the ventricle?
Well, that's a great question. So Dr. Levine has written about
they do the outside.
They do some,
if you're a sheep, you do very well.
They go live forever. But the reality is that the technique we would use is probably through inside the ventricle. But there's just anecdotal studies.
And does that mean papillary muscle activities and things like that? You think?
That's my belief. Yes. There's no data to support it.
Okay. So now you're telling me that if you've got severe ischemic MR, that you've got to really look at the basal inferior wall. Is that right?
Correct.
See, that's going to be important if you're thinking about repairing the valve.
And I think if you don't see that, the repairs actually do pretty well.
Okay, that's okay. What about moderate ischemic MR?
Yeah, that's a great question as well.
I mean, that's the question that always comes up. I'm in there. What should I do?
So
have the trials taught us anything?
I think they've told us a short-term answer. I'm not convinced we have a long-term answer. So at 1 year, the moderate trial would suggest that doing a bypass alone, patients will do as well. Now, if you look at the data carefully, it looks like adding a mitral repair does not increase the mortality. They just don't do any better. But a lot of the patients are left with moderate MR. So what's going to happen to them at 3 and 5 years is not clear.
So you're saying in moderate MR, it's a given that you should revascularize properly.
Correct.
And then doing a repair in those patients doesn't increase operative mortality.
Correct.
And you think it might do them better down the road?
We don't know yet, but what we've put together in our guidelines, which you're going to present this week.
That's what I want you to know.
Yeah. If you come in with angina, this makes sense, doesn't it? If you come in with angina, fix the angina.
Fix the angina.
If they come in with heart failure, you better do something about the heart failure. And the decision should not be made in the operating room. And you've taught me that over the years.
But does that mean that when you say you come in with heart failure, are you going to go down the best medical treatment and all that sort of stuff, or are we talking about an medical and operative approach to treating the heart failure?
So part of our guidelines is you need guideline-directed medical therapy. Correct. And once you've done all that and they still have heart failure, then you ought to do something.
Do something to the valve.
To the valve.
And obviously the
and bypass.
So the final thing I have to ask you, unless you want to talk about anything else, which is good, what about transcatheter therapies in this population?
Oh, that's really interesting.
You can't get out of the our cameras can follow you.
So we got at our place Scott Lim and Gorval White. I think Scott has probably done as many clips as anyone in the country.
You've got some very talented guys.
And the way it works, and this really does work this way. I know it sounds odd, but we actually get together and talk about these folks, and there's no major disagreement. So, where transcatheter therapy is now for mitral valve disease, it's indicated if you have degenerative disease and you have a prohibitive surgical risk, and no one argues that. Now, what about this crowd?
What about this crowd? We don't know yet.
We don't know yet. The COAP trial is just being enrolled.
Right.
We're actually number one enroller in that. And these are people who get medical therapy versus the clip. And the clip does what it does. It leaves you with some MR, but the fact is it doesn't hurt a whole lot of people.
Correct.
That's reality. So we don't know. But I got to say, if I had someone who had prohibitive risk and had bad heart failure and had ischemic MR, why not? Why not?
I think you're right. Well, I mean, it's going to be good to see what your guidelines say. I think that'll be it. But I do think that we're getting a little clearer picture, at least. I think the way you open this is that you'd think was counterintuitive, that you'd think, because you would think you're replacing it, you're going to do harm and all that stuff. So the trials have been very, very useful.
Oh, it's so.
I know you've headed those up, so I think it's really good.
No, it's been a huge thing, and we've learned so darn much about it. And you cardiologists understand about trials forever. But we sit there and we've done 50 of these so far, so good kind of papers.
And you've got some nice, quiet, shy or quiet guys on you.
What a crowd.
It is a crowd. Listen, thank you very much. Good to see you.
Great to see you.
Thank you, my friend. Thank you.